Great, thank you so much. So I'm going to talk a little bit about how the guidelines for the treatment of GERD address DEI. And this is my disclosure slide. I am a consultant for Boulder Surgical as well as Cook Medical, but that is not relevant for this presentation. So these are visual abstracts from the GERD guideline that was published about a year ago now. The top panel is the guidelines for adults for GERD, and the bottom is for pediatrics. So I'll just take this opportunity to quickly remind anyone who isn't familiar with the guidelines what we found. So for patients with chronic and refractory GERD, the first question that we tried to answer was, is medicine or surgery better? And we found that surgery was better than medication for this population. Additionally, then looking at robotic or laparoscopic, if the goal was to minimize long-term PPI use, robotic was better. If the goal was short-term symptom control and avoiding reoperation, laparoscopic was beneficial. For partial or complete fundoplication, if the goal was to minimize reflux, a complete fundoplication was more beneficial versus the goal of minimizing dysphagia, in which the partial fundoplication was beneficial. And then finally, in the adult population, we looked at dividing or preserving the short gastric vessels. And if the goal was to minimize reflux, dividing the vessels was more beneficial versus the goal of reducing procedural complications and long-term gas bloat. The beneficial portion was for preserving the gastric vessels. And then we did do subpopulation analyses for pediatric patients. Unfortunately, there was not very much data to answer a lot of our key questions, but when we specifically looked at maximal or minimal dissection during a fundoplication, we did have moderate evidence to recommend a minimal dissection. So I must admit we did not use questions surrounding DEI very extensively within this guideline, which then got me to look in the literature to see a little bit more about how we could have incorporated DEI within the GERD guidelines and how it can be incorporated into later guidelines. So as you all know, GERD is a very common disease with a high incidence worldwide. But for different patient populations, the prevalence and severity will differ. So looking at these bullets here, I put specifically looking at pediatrics, gender, socioeconomic status, and demographics are just some of the patient populations that are going to have different prevalences. So again, we did try to look at pediatric population in our GERD guidelines that we've already published. However, as I mentioned, there were not very many comparative studies, so we weren't able to make a lot of recommendations. And then furthermore, within the pediatric population, which is true for many disease populations, there are often subpopulations within that group. So specifically for GERD, there are patients that are neurologically impaired and those with congenital anomalies for which treatment strategies may be different. Similarly, looking at gender, in the literature, there are certainly differences in the prevalences of GERD between male and female gender. And even more specifically, when looking at symptomatic GERD or the rates of complications, there's also differences between male and females. So I found this study cited at the bottom of the slide here. That was a study sent nationwide to gastroenterologists that made up fictional questions regarding GERD complications and presentations. And there was actually no difference in treatment based on gender within these scenarios given. So despite the fact that there is known prevalence differences between the gender, there was no differences in the treatments because of the gender. I tried to look up some literature regarding socioeconomic status, specifically related to GERD. There is actually not that much literature that I could find on this, but there was this one interesting study from southern Iran in which they looked up baseline data of demographics as well as GERD prevalence there. And they looked at the concentration index as well as the concentration curves, and they used that to measure socioeconomic related inequalities in GERD. And what they found was certainly very significant socioeconomic inequalities related specifically to GERD. And of course, we know there's differences in access of care as well related to this topic. stepping away from sort of the population aspect, the other very important aspect when looking at DEI in the guidelines is the implementation portion of the guidelines. So with GERD, there are a lot of different diagnostic tests that are done, but there may be varying degrees of availability both globally and rurally. For instance, some patients might not have access to impedance testing at some hospitals within the world or the United States. And certainly when you look at endoscopic treatments, there might not be access for patients to things like strata and TIF. So for future recommendations within the guidelines, it's very important to look at all of these aspects. The inequalities really should be addressed to identify these vulnerable subgroups and then ideally to help reduce the disease burden within the community. Furthermore, studies are needed to determine if these same treatment strategies that we recommend in our guidelines are effective for different populations. And then we would need to standardize and prioritize the treatment strategies within these populations. Thank you very much. I'd be happy to answer any questions once we finish the rest of the panel.